Yes, welcome to everybody. Those of you who's joining us for the first time, I'm Corlius Birkill. I'm the CEO of Xavant Technology. We're the manufacturers of the Stimpod NMS460 based in South Africa. And as many of you know, we've just recently introduced it in the US, and we're extremely excited by tremendous interest in this alternative to opioids and many other drugs. So we have had several requests. The request for the first webinar was for diabetic neuropathy. So we focused our first webinar on that. It was partially recorded, so you're welcome to go and view it on our website. Obviously, we're recording this one. We'll also post that. We're currently busy with a couple of specific protocols, treatment protocols, so you can look forward to definitely one that will follow this webinar on different types of headaches, especially migraines and tension type headaches. We're busy with one on Bell's palsy and a couple of others. So please, we will definitely send out emails to remind you as well, but please check out our website from time to time. Great. Phyllis, I think without further ado, well, just tell me a little more about your practice. So you guys have a pain management practice.
Yes, yeah? And there are 5 physiotherapists, and we all use the Stimpod. In fact, on almost every kind of patient that we see, we see fibromyalgia, severe chronic pain from post-operative surgery, complex regional pain conditions. Basically, any type of chronic pain, we have used the Stimpod Plus. We use other therapies, of course, but we found that using the Stimpod has actually changed the pain for many patients within 3 sessions. And we find that when patients are not coming chronically for months on end, we are actually able to end the pain for these patients.
Fantastic. Fantastic. And does that count for the headaches as well?
Yes, it does. So we can talk about the headaches today.
Wonderful. Before we start, Phyllis, just a couple of administrative comments. If you have any questions, please send them, as Susan just did. Just send them by message. I've muted everybody, otherwise we often pick up problems with this time. So please feel free anytime during the presentation to ask questions via the messaging system. You can either let the whole group see it or just myself. It doesn't matter. We'll keep it private if you want it to be private. And we will answer them at the appropriate time throughout the presentation, but definitely at the end of the presentation we'll have a couple of minutes for specific questions and answers. Susan asked whether we'll get the PowerPoint will be made available. Yes, definitely. Actually, the different types of treatments that we show in the PowerPoint will be done in a similar format as the one that we did on diabetic neuropathy. So specific protocols for the treatment, and will be posted onto the website probably in the next week. I'm looking at my digital marketer to confirm, and he's just given me the nod. He's also our model today. So you'll see a little more. He's got a huge headache because he was under pressure to finish this PowerPoint. So tension type headache. All right, Phyllis, please let's start with the PowerPoint and tell us a little more about headaches.
Well, as we know, headache disorders are the most prevalent of the neurological conditions, and among the most frequent of medical complaints seen in general practice. The most typical headaches actually are tension type headaches and migraine. But we also have trigeminal cephalalgia, cluster headaches, and these are rather rare. Primary stabbing headaches, trigeminal neuralgia, and persistent idiopathic facial pain. These are rare, but they can be treated with a Stimpod. Half of the general population actually experience headaches during any given year, but more than 90% report a lifetime history of headaches. In fact, the most severely disabled...
Sorry, Phyllis, I have to interrupt. We're just getting some comments, so it's very hard to hear you.
Oh, dear. Okay.
So, yeah. I don't have a way to hear you.
Okay, I'll do my very best to speak more loudly than that. Okay, the most severely disabled number, 3%, and experience of headaches such as chronic migraine and chronic tension type headache at least for 15 days per month. So when we look at tension type headache, the clinical features are mild to moderate intensity headache, a pressing or tightening sensation on the head, but not pulsating, and they're not aggravated by physical activity, such as walking and stairs. Is everybody happy to hear me now?
Yeah, we got feedback that that's much better. Much better, thanks. Let me just ask you some questions about these clinical features. So obviously they're different from migraine. I know, for instance, we'll get to it, that migraine is aggravated by physical activity. Is that correct?
Yes.
And obviously quite important to be able to diagnose it accurately. What would you say is the biggest differentiation here between tension type and migraine?
Well, with tension type, it really is coming from myofascial pain and joints. And the joints could be cervical, TMJ, temporomandibular, as well as a central nociceptive imbalance due to sensitization for patients who've had headaches for a long period of time. Whereas when we're looking at migraine, it's something to do more with what's happening in the brain. And we'll go into that just now.
Okay.
But if you're looking at the some of the pathophysiology, there's definitely evidence of tenderness in muscles on the head and neck. And the muscles involved are occipitalis, frontalis, temporalis, trapezius, sternocleidomastoid, and along the nuchal line, and others that may be indicated that I haven't mentioned. So if we have a look at this diagram next, you will see that some of those muscles that I've mentioned, for instance, the occipital belly of the occipital frontalis, and if you're looking at the frontalis aspect of that muscle, you can see that there can be referred pain from the posterior aspect to the anterior aspect. Let's just go on to the next slide, which gives us some insight into the difference between the occipital nerves and the trigeminal nerve area. They are very close to each other, but yet the one comes from deep within the brain, the trigeminal nerve, and the occipital nerve exits from the spinal cord posteriorly. So let's just look straight away at our treatment options for tension type headache. The typical options normally that you would possibly give would be a combination of medication and non-pharmacological treatment, including relaxation of muscles, biofeedback, trigger point injections, physical therapy, and exercise. Now the Stimpod adds another dimension, because you can...
I'm so sorry to interrupt again. It seems like it's fading again a little bit. Let me see. I can get you a little closer, yeah. How's that?
Is that better for you? Is that, can people hear me?
I think
more. All right, is that easier?
Yeah.
So let's apply the Stimpod to a tension type headache. So we're going to have neural stimulation of cervical and trigeminal nerves and their branches and trigger points that are available in the muscles. So we would apply the treatment probe to occipital nerves such as C1, C2, and Q3, and we can see it in the PowerPoint presentation to follow. We would also look at the auriculotemporal and mesenteric branches of the mandibular nerve, which belongs to the trigeminal nerve, for the TMJ joint, because those nerves surround that particular joint. And then if we have a stiff neck or neck pain, we might use the facet joints C1-2, or C2-3, or C3 and 4. Then, if we have spasm from lower cervical joints or nerve root compression, we might treat the brachial plexus, which are the nerve roots that exit the foramina from C4 down to C7. And those are the facet joints that you would see the nerves emanate from. And any other area of referral is a trigger point. In fact, when you actually treat the patient, we can ask the patient if the current follows the path or trajectory of the headache as we apply the current. And this may indicate that we have targeted the correct nerve. duration of treatment should be 5 minutes on each nerve site, and it can be unilateral or bilateral. Unilateral is mainly with migraine, but if you've got tension type headache, you very often find that the neck is very stiff, so therefore it might be rotations from both sides, so then I would suggest you do bilateral points. If the condition is severe, I would use 10 minutes on a specific nerve site, because 5 minutes may not be sufficient. But however, I would definitely try 5 minutes initially, because you don't want to irritate the patient and you want to see what the effect of 5 minutes is. Sometimes it's excellent.
I would just like to revert back to the previous slide, if possible. I just have a couple of questions for you.
Yes.
All right, so we've got two components here. So the one is that we're treating nerve,
Yes.
the occipital nerves, the occipital nerves, and then the different branches of the trigeminal nerve. Okay.
Yes.
But then you said that we also, and obviously with that we can treat any neuromodulation aspect of it.
Yes.
But then we also have facet joints that we're treating, and this is a mobility issue.
Well, why are you treating the facet joint? Because you're actually treating the nerve root as it exits the foramen.
Okay.
And that's why it's actually not a joint that we're treating, but it's the nerve supply that emanates from that particular level, and therefore will supply all the muscles surrounding that region.
Okay. Okay, and then you say, obviously the tension that can be made worse due to spasms or whatever, and then we'll treat the brachial plexus.
Yes. If the patient has got mid to lower trapezius muscle spasms with their headache and with the stiffness in the neck, then you would wish to go lower down to the facet joints C4, 5, C5, C6, or 7. But sometimes the patient is very, very sensitive. So therefore, I tend to go to the brachial plexus, and if we go to this diagram,
okay, hang on, I have to catch up with you.
Catch up with me.
All right, hang on. There we go. All right.
Then you will notice that the brachial plexus is a bunch of the nerves bunch into a plexus as they exit the foramina, and they are accessible just above the clavicle and also below the clavicle. So you may be able to access them in two different regions. And this can be useful because if a patient has surgery and you cannot get the lower brachial plexus aspect, you might want to do the superior one. It just depends on the symptoms of the patient and how they would manage the treatment. But if you go to the brachial plexus, you are then stimulating every single nerve from C4 down to C7 or T1. And the treatment itself will traverse all the way back up to the facet joints at those levels, and therefore treat muscle spasms, treat the nerve, and improve mobility. You always get an improvement with mobility when you treat with Stimpod on the nerve. In fact, you don't have to do as much mobilization. You can then go on to for exercises and your posture correction once you've treated the nerve supply to the particular joint or muscle that you're wishing to treat.
All right. Wonderful. Thank you. Okay, so shall we revert back to the specifics of the treatment?
Yes.
Okay, I think we were looking at...
I'd like to go to frequency. Yes.
All right. Did we do duration?
Yes, we did. We can go back.
Yeah, if you can just repeat that again, please.
I'd just like to say that your duration of treatment could be 5 minutes on each nerve site that you decide on. And of course, it can be bilateral. It would be bilateral with a tension type headache, but it may be unilateral because the patient may indicate that one side of the cervical spine is more stiff than the other. So therefore, you may decide that the problem is coming from the left side as opposed to the right.
Right.
So if the condition is very severe and you get given at least one treatment with 5 minutes and you've seen the result of the treatment, you might decide that this patient would be best served by giving a 10-minute treatment on a specific nerve site. So, but I would see that the first treatment there are no ill effects or patients are not have got increased pain. Then the frequency of treatment. If it's a very acute situation, I would treat daily. Otherwise, we would go to 3 times weekly or twice weekly. And if a patient has got ongoing chronic situation, up to once weekly or twice monthly, and you can even go down to once in 10 days and then once monthly, so that you are reducing the number of treatments patients have.
All right, let me just understand this correctly, Phyllis. Okay, on that slide, in terms of the maintenance, okay, so are you saying that the initial maintenance will be once weekly and then it will reduce to bi-monthly?
Very much. It could be, or it could be 1 10 days and then bi-monthly and then once monthly. It just depends on the patient, and if you decide that that patient really requires that sort of treatment, but many don't. We really rarely see patients like that. But I just wanted to give you an idea of how you could progress your treatment. Okay,
so that's actually a process of weaning them off the treatment as the requirement.
And actually, most patients will respond within 3 to 6 treatments in total.
All right. So do you get a situation where, thanks, Larry, do you get a situation where patients come and they've got a severe complaint about a headache, they come for 3 treatments, they're 80% better, they're supposed to finish 6 treatments, but because they're 80% better, they just don't look up for the 3 treatments?
Well, we communicate with our patients straight after every single treatment, and we follow their improvement. And usually patients will tell you that they really feel very much better. And by the 3rd treatment, they often haven't got a headache, and then we are able to treat the joints, give them exercises and postural correction and lifestyle correction, etc. So it's very valuable to see the patients and then to have follow-ups to confirm them and find out how they're getting on. And then we encourage them to come back to us if the headache returns. And very seldom do they come back. They come back months later or even a year later or so or more. And they'll say, well, I was fine, and now I've done something, and the headache started again.
Right.
And we don't often see our patients come back because they do well.
All right. Okay, excellent. Okay, well, the next issue that we're going to address is the intensity of treatments, and I know that's a confusing issue for many people starting out with treatments on the Stimpod NMS460. What is your recommendation?
Well, when it comes to headaches, I like to start low, because it's a very, very sensitive area. And if you're treating the trigeminal nerve, it's a sensory nerve. You do not want to irritate the patient. And these patients have got severe pain. So I like to start with 1 milliamp to start with. And if the patient's comfortable with that, I push it up to 5 milliamps. And if the patient tells me that they can hardly feel it, I'm happy to carry on. If the patient experiences no irritation whatsoever, we'll increase the current to maximum that the patient can tolerate, or until I start to see a little pulsation coming out of the muscle above the nerve. So that's the way we go to start. We start with the patient.
Okay, excellent. We had that question a little earlier. If you have any further questions, send it. Okay.
I'd like to just say that with headaches, you tend not to go too high with the current. I mean, you wouldn't really go to 15 milliamps easily, because that's much too high. You've got a lot of bone covered by very little skin and not very big, large muscles, so it's quite important.
Okay, so it should be sensitive when treating.
Yes.
And look at the feedback from the patient, those grimaces and teeth chattering. All right.
The next diagram is just a diagram of the cervical spine, looking at the upper cervical spine from C1, C2, and C3. So you've got your atlas, your axis, and your 3rd cervical vertebra. And you can see that the nerves emanate from the facet joints at those levels. So we'll go on to the next. Now the next slide is a very interesting slide, because it actually shows you the suboccipital nerve and I'm not sure that I can do this on the diagram here. I don't think so.
Right now, yeah.
All right. Well, if you actually print out this diagram, you will see that the suboccipital nerve is above the atlas, and you can see the area of the atlas exposed. Actually, I'm just do it on mine so that it just shows Corlius where it is, and that it comes from the dorsal ramus of C1. Dorsal ramus of C1. The next one is the second cervical nerve, and that comes from the dorsal ramus of C2. And then the next one that you can see it's like a dissection that we're looking at this picture on the right hand side. You will see the dorsal ramus of C3. And then if you look at the other side of the skull, you'll see that the greater occipital nerve actually runs right up on the back of the skull, and that is coming from the greater occipital nerve C2. Then your third occipital nerve is coming from C3, and that is a bit more central. And then you will see the greater auricular nerve and the lesser occipital nerve. They both emanate from C2 and 3. And the lesser occipital nerve goes into the muscles of the trapezius, whereas the greater auricular nerve travels behind the ear and is maybe responsible for dizziness and other types of symptoms. So we can treat many kinds of symptoms by targeting these specific nerves.
Thank you. I just want to mention to everybody, I know this is a little unclear on this diagram. It will be redrawn when it's posted onto our website, and the specific target areas will be made very clear. But if you read carefully, we just highlighted obviously the text that you're supposed to see. It will be redone on the website.
Maybe we'll put them in lime green so that you can actually distinguish them from the tissue below. I think that might be easier for you.
Great. Okay. So there's the brachial plexus one.
Yes, and now we can go on to migraines.
All right.
And we can look at the difference between the tension type. So with migraines, it's recurrent pain that is severe. It's often unilateral and it's pulsating. You may also get sensory disturbances, which we are known as an aura, and it's affected by light, sound, or odors. Patients may have nausea or vomiting. They may have neck stiffness, and that again indicates that we ought to be treating the cervical joints. Okay. They may have dizziness. Symptoms are aggravated by movement, such as walking or climbing stairs. You might see a patient coming in and holding their head because any movement disturbs them. Right. And symptoms may occur during, prior, and in between migraine attacks. And you may also get simultaneous disorders that may be present or predispose the patient, including anxiety, depression, fibromyalgia, back pain, hypertension, a stroke, cardiac disease, or even childhood vomiting.
Is it sometimes possible to get an aura without a headache?
Yes, indeed. And in fact, that's a good time to even treat the patient, because you might be able to prevent the headache moving further. Okay.
And I believe it's like a perfect storm happening in the brain. I know there's a couple of different series, two main different series for generation of migraine.
Yes.
There's also a notion that I've read recently that tension type headache, and it's just lesser symptoms of a migraine, that it's actually a progression of the same symptoms bleeding from one thing to the next.
It's possible. It's very possible, and that's why when you see stiffness of the neck, it sort of makes you think, well, maybe it starts with that, and then it can develop. And if a person is genetically predisposed or has other forms of chronic pain, it sensitizes the nervous system, because it's actually, according to some of the information that I've seen, migraines are due to a dysfunction of the central nervous system at several levels, and we consider it a neurological disorder of the brain with cortical spreading depression and abnormalities in the vasculature occurring actually secondary to the primary neuronal event. And patients, once they become sensitized to pain, the whole nervous system is disturbed, from the spinal cord, dorsal root ganglion, and supraspinal levels on the brain. So anything's possible.
Let me ask you the reverse. If someone's got a headache but with no aura, could that still be in migraine?
Yes, it can be.
But how would you distinguish it? Just due to the fact that it's aggravated?
No, because it's unilateral and it's very severe and it pulsates and it's painful to walk.
Okay.
And things like that. That's how you distinguish.
All right, great. Okay, sorry, I'm playing catch up with you.
Sorry.
All right, there we go.
So here again is the diagram of your occipital nerve areas, but it's very close to your trigeminal nerve areas, and you can see the auriculotemporal nerve, which is anterior to the ear, and various other branches. We'll go on to looking at the trigeminal nerve, which is the largest and the most complex of the 12 cranial nerves. It supplies sensations to the face, the mucous membranes, and other structures of the head, and that's why it can be used for tooth pain. Very often patients have got very severe pain after having been to the dentist, and this has been going on for months on end, and you can actually treat the various branches of the trigeminal nerve because it will relieve these sensations.
That's very interesting. Yes, I'd like to swing back to that because you mentioned to me in a previous conversation that sometimes you actually treat inside the mouth for dental pain.
Yes, you can. And also for what's called xerostomia, which occurs when patients have had radiation for cancer of the mouth, and these patients have got no saliva, so we can actually stimulate the inside of the membranes and produce saliva, as well as the area of the parotid gland on the face.
Excellent.
So should we go on with the trigeminal nerve?
Please.
Because it is a motor nerve for muscles of it's also a motor nerve for muscles of mastication, and it contains proprioceptive fibers so that you can tell where the food is in your mouth. And it exits the brain by a large sensory root and a smaller motor root coming out of the pons at the junction with the middle cerebral peduncle. So you've got various divisions. You've got an orbital division, which is going towards the eye, an axillary, which goes across the temporomandibular joint and also towards the nose, and then you've got the mandibular branches, which go into the jaw.
Excellent.
Here is another diagram which just shows you the orbital branches as they exit the eye, the orbit of the eye. You can see the different nerve branches, but it would be very interesting to be able to put your probe around the orbit of the eye if a patient's got a very severe headache. But I would then use a very, very low intensity, say 1 or 2 milliamps in that region, because it's a very sensitive area, but it could be a very, very good position to actually target the pain. And also, if you're looking at the nose, or the nasal area, you can also get to the trigeminal branches there, because they also create a running nose, as well as when you get into the orbit, you can have tearing of the eye. There's so many different symptoms that you could actually treat. And again, the next picture just gives you a diagram of the bony landmarks that the trigeminal nerve overlays. So you can understand why with TMJ problems, the trigeminal nerve could be very valuable, and you would then treat that region for the pain in the TMJ. And this excellent results is that immediately you treat the trigeminal nerve in that region, the patient can open their jaw, and they can move the jaw sideways and anteriorly as well. So that's a very interesting treatment to give the patient. And so often we know that patients say to you, I think my headache's coming from my jaw, because my jaw muscles feel stiff. So therefore you can help the occipital type, the headache in the temporalis muscle, relieve by treating that region.
Great. Fantastic. So, okay, so now we're looking at the different treatment options
for migraine.
Yeah.
So normally you would use, can I go on?
Please do, yeah.
So normally you would use a combination of medication and non-pharmacological treatment, including patient education, to identify and actually avoid the triggers. You must maintain regular daily activity and aerobic exercise and weight reduction if necessary. we may use biofeedback, acupuncture, and relaxation techniques, and then CBT, which is cognitive behavioral therapy. And then there's ongoing investigation in various studies on electrical brain stimulation techniques. And I would just like to go back to the relaxation techniques. If you can relax the muscles, you get less pain with migraines or any form of headache. That's why using the Stimpod will benefit these patients as well. Going to get relaxation of the muscles. So we could then use the neuromodulation of the Stimpod on the occipital and the trigeminal nerves, but possibly we would go to the trigeminal nerves first. And then you may also want to use your autonomic nervous system, because the patient may have sweating, they may have increased heart rate or various other symptoms. You will see the hairs raise on their skin, or they may have other symptoms of autonomic nervous system disturbance.
All right.
So you could then go to the thoracic nerves. You could start at thoracic 1 and go all the way down to T6 or even T10, because we know that the autonomic nervous system is treatable by using the thoracic nerves from T1 to T10 or T6. So you may be able to get some effect on patients by treating that level. And you would just see whichever level you think is most would affect the patient.
That was very interesting to me. So, I mean, obviously, the main offenders in terms of the nerves for migraines is the occipital and trigeminal nerves.
Yes.
Interesting that you brought the autonomic nervous system into it as well, and that it's, I didn't actually know that you can access it there from T1 to 10.
Yes, you can. And you know, the interesting thing is that I'm an acupuncturist as well, and these are the points that we actually needle for autonomic nervous system.
Interesting.
Yes.
Excellent. We just had a question here. I just want to interrupt quickly, Susan, with regards to the video. We're actually going to do an actual treatment at the end of this presentation. So let's see how that goes. And if you have more questions after that, please let me know. Okay, so the detail of the treatment.
Yes. So we're going to look at occipital nerves C2 and 3. And we'll look at trigeminal nerve branches, including occipital, maxillary, mandibular, and upper or lower gums. But I mentioned that I probably won't do all of that today because we're not looking at that aspect, but we will do that possibly in another video, another webinar. We can look at facet joints C1 and 2, C2 and 3, and C3 and 4. And then lower cervical spine if we need to, brachial plexus. We'll look at trigger points in muscles. Very often at trapeze, got these very hard trigger points, and you can actually stimulate those trigger points. You'll get relaxation and improvement in your movements as well. Although we discussed the nerve points, we are activating muscles which are situated above those nerves in the muscles. And then any area of referrals, patients get unusual primary and secondary trigger points, and therefore we might go to the secondary trigger point and treat that, and it can relieve pain, which could be in your mid-trapezius or lower trapezius. And again, as I mentioned, autonomic nervous system. And if you've got sensory sensitivity, nausea or dizziness, then treat your occipital trigeminal referral sites and your auricular nerve branches, because very often elderly patients have got dizziness from vestibular problems. And we often use the occipital nerve and we use the trigeminal nerve.
Okay, and the auricular nerve branches for the dizziness.
Yes,
okay.
yes. And again, we ask the patient if the current follows the path or trajectory of their headache, and this may indicate that the correct nerve is targeted.
All right. I think it's crucial to emphasize, the patient participation in the process, because you will actually get that referral if you get to the correct nerve, isn't that? And or you may immediately get a relief when you start treating a nerve as well.
Patients will tell you as soon as you start, oh, that feels so much better, or that is exactly where my pain is.
Right.
And I stop the patient. I stop after 5 minutes and I check the movement and I check the patient straight away. And if they tell me that they're feeling better, then I know I'm on the right area.
Excellent.
So for the duration, it's exactly the same as what we've done before, and I'll just repeat it. 5 minutes on each nerve site. Well, mostly it will be unilateral with migraine, but definitely use bilateral if you decide that the symptoms warrant it. And if the condition again is severe, 10 minutes on a specific nerve site, but I really would caution to use a low intensity. And again, your frequency of treatments daily in acute conditions, and otherwise it's 3 times weekly or twice weekly. And again, maintenance, same thing, once weekly, once in 10 days or twice monthly, and then once monthly.
Right,
and
so
again,
gradual
tapering off if you need to.
Right.
But, you know, some of these migraine, they've had patients, they've had pain for years, and there's been nothing that's helped them, and they've been on extreme medication. So these are patients you may have to consider maintenance for.
Correct.
And again,
okay.
Most patients will respond to 3 to 6 treatments in total.
All right. Do you ever see, again, I mean, we discussed this in the diabetic neuropathies before, that possibly after the first treatment there may be a little bit of an irritation?
Yes.
Or...
Yes. Sometimes, and I warn the patient, I've said that if you feel that there's more pain after the treatment, it doesn't mean that you are not going to get better. But let's see what you're like by the next day. And very often the patient will come and say, oh, I was quite sore that day, but this morning I'm very much better. So that means, you know, I've seen them on the next day. And then I know that exacerbation was just due to the treatment soreness. But then I'll probably give them less current, reduce intensity, and make sure that the patient is comfortable. But they'll say to me, oh, you can increase the intensity. I'll say, are you absolutely sure? And they will usually, they don't mind because they know they're getting better.
Excellent. Okay, wonderful.
So if we go on to, again,
right, just the intensity of treatment.
Excuse me. So you're going to start with your low current, 1 to 5 milliamps. And again, if there's no irritation, you'll increase your maximum that the patient can tolerate, or until you possibly see a circulation, if it is visible for you on that particular nerve. I mean, if you're doing the orbit of the eye with the trigeminal nerve, you may not see any circulation. But then bear in mind that the facial nerve also supplies muscles overlaying the trigeminal nerve, and you may activate some of those. But if you know you're in the correct position for the trigeminal nerve, then you should be relaxed about that. And if you do see the circulation, it doesn't really matter, as long as the patient is comfortable. So if the patient complains of discomfort, you reduce your intensity, and you remain at that reduced level unless the patient requests an increase in the current.
Great. Okay, thank you. So I think that covers the essential things of migraine.
Yes. Do you think we need to carry on with the trigeminal autonomic cephalalgias? Do you think we'd like to?
I think so, yeah. I think, I mean, treatment's very similar, I believe.
Very similar.
But maybe it's just for audience to know the difference.
Yes.
Yeah.
So it's also, the trigeminal autonomic cephalalgias are also known as episodic and chronic cluster headaches because they don't last very long. They're episodic and they're chronic paroxysmal hemicrania, which means half of the head. Very short-lasting, unilateral with severe headache attacks. And they're typical autonomic symptoms such as you may get conjunctival injection and tearing, which includes reddening of the eye or tearing, nasal congestion and runny nose, and sometimes you get eyelid edema. And the pathophysiology behind this is a trigeminal-vascular nociceptive pathway, as well as a reflex cranial autonomic activation. So it's deep in the brain, and it's something that we can't always access easily. So it's highly specific activation of the hypothalamus, the hypothalamic brain, in the cluster headache, and you have involvement of the pain process in a permissive or a triggering manner. So it's usually activated by somebody who's got sensitization in the nervous system in the brain. And it's unusual. It's sometimes, well, it comes about with patients who are older, usually over 60 years of age, and possibly more females than males.
Okay.
And the treatment options for these are usually medication and non-pharmacological treatment. And in the acute phase, oxygen treatment is very successful with about 80% of patients. But we can add the Stimpod, and we would use neuromodulation of relevant nerve supply, which may affect vascular symptoms and local autonomic symptoms. So we would be very careful with these patients, but they may not come to you when they've actually got the headache. So they might come in saying that they have these types of headaches. So then we would look at the symptoms that they may have. They may have a stiff neck, or they may not, or they may, you may have to look at various aspects and then decide where you would treat. So you would apply your treatment probe to trigeminal nerve branches according to their symptoms that they have described to you. So they would be either orbital, supraorbital, temporal, maxillary, mandibular, if involvement is present, and again on your occipital nerve C2 and 3, and possibly your autonomic nervous system T1 to 6 or 10, and then your facet joints C1 or 2, C2 or 3, and your trigger points in muscles, because sometimes, believe it or not, a trigger point could be responsible for.
Right, Phyllis, I think you can.
So we can just say that the number of treatments, 3 to 6 treatments in total, but I was going to say to you that with these patients, I would actually treat longer. I would possibly treat for 12 treatments, because you aren't going to usually see them during the headache phase. And then we need to monitor exactly what's happened, how many headaches they've had in the day or in the week, etc. And then we'll know if we're actually helping their condition. The next slide I'd like to show you is the facial nerve, because I just want to take you straight away to a visual of the facial nerve and the branches that are very similar to the trigeminal nerve, except they are lower down, and the facial nerve exits the parotid gland, and you can see your ophthalmic and your maxillary and your mandibular branches. So I just wanted to show you the difference. They are very different to the trigeminal nerve, and they are lower down, but yet they are in a similar region. So basically,
excellent.
Just to give you that.
Okay. Phyllis, just a quick observation. I'm just sliding back to the treatment probe. So it seems that for just about all the conditions, we're looking at occipital nerves and facet joints. I mean,
yes.
That seems to be a common theme.
Yes.
And correct me if I'm wrong, but with migraines, we're adding the trigeminal vascular complex, yes, or treating yes. that through the trigeminal nerve.
If you go back to that diagram of the posterior aspect of the head, where you see a dissection. Right. Of the back of the head, you'll see all the blood vessels there and the nerve situation above the blood vessels, and so therefore you must be stimulating the blood vessels as well, right, when you are activating the various nerves.
Okay, all right. So there's a muscular component that gets triggered yes. as well.
Yes.
Okay, great, wonderful. I think. Shall we do a demonstration?
Yes. Yes.
I think Lori's head is twisting by now.
Oh, no.
Let's get him up there. Thank you very much. If you have any questions so far, it'll be a great time. Just while we switch cameras and we do the setup, I'm going to stop sharing my screen.
All right. I'm going to put the reflex electrode, as you call it, but I call it the indifferent one, far away from the actual site of the nerve area that I'm going to treat. I'm going to switch on my Stimpod.
Fantastic.
And I'm going to then start off with the C1 nerve, the suboccipital nerve. And here we can see the posterior aspect of the skull, and we have muscles that are, the nuchal muscles that are attached there. So I'm going to go quite high up to activate these muscles. And I'm going to put my my Stimpod onto 0.2 milliseconds and 2 hertz. And I'm now going to turn up the current. And please won't you tell me, Lauren, what you feel.
Starting to feel a sensation now.
You are. It's not too strong for you?
No, you can go.
Tell me how far I can go.
Okay, this is going through my hand. I'm also feeling it down on the electrode.
Yes, you will feel it down on the other electrode, but it's not active. You may feel it, but it's not active. And I'm looking now for the nerve supply. And I might find that I'm on 13 milliamps. Here you go. Can you see activity of the occipital muscle? And that's coming from C1, the nerve from C1 ramus. Now, I'm going to go on to the next one. I'm going to turn down the current. Start again from 0. And I'm going to move on to the C2 nerve, which is situated between the trapezius muscle and the sternocleidomastoid muscle. There's the sternocleidomastoid muscle, and there's the trapezius. So I'm going to target that nerve. I'm going to switch this on, and then we are going to, can you see, at 17 milliamps, I pick up a circulation. How does that feel to you?
It's comfortable.
Comfortable. And do you feel it's going through to the front of your head?
Not yet. It was on the other nerve.
The other nerve, you felt it. Because that's occipitalis and frontalis are all one muscle, but just in different regions. So that nerve would be a very interesting nerve to target for the front of the head.
Okay.
So you can go right up into there. Now, let's go down to C2 and C3, which is lower
every
down.
time you adjust and you turn the current down
Yes.
to 0 milliamps, and then you're going to go up slowly again.
Because otherwise you might give the patient too much current, and that would distress them. So
Right.
now we're looking for, we just go lower down, and I actually can feel the facet joint. Okay. I'm looking for C1, that is the atlas, that's the first vertebra, as you know, and there's the second one, and that is the third vertebra at that level. So I'm going to go more onto the facet joint, but I could also go into this region here, and I'll show you the effect. There you can see that's the trapezius muscle activating. Now I'm going to go down again, and I want to try and go onto the facet joint and show you what would happen. You can see it's much more active because it's the nerve root that exits from the facet joint, the space between the joints.
Interesting.
Yeah.
Right.
So now let's have a look at your trapezius muscle. If you've got a very strong trigger point, for instance, there, that's a trigger point for you, isn't it? Or probably not sore. Not sore. Okay. Let's just see if this one would be sore. There.
Yeah.
There is one that's quite tender.
Right. I was worried Larry's falling asleep on
I
that.
think so. Oh my.
Very comfortable.
Okay. So now we go to this trigger point, and it's offering a really strong treatment to a trigger point, and you don't even have to put your finger on and press strongly down as we usually do if you're using your fingers to do a trigger point release, or you could put a needle into that area. But here, by giving 5 minutes on a particularly painful trigger point, you improve your range of movement, and you improve your pain, and you'll improve headache.
Okay.
So,
Phyllis, can you take a moment just to tell us about what a trigger point is, and why do you release it, how do you release it?
well, a trigger point is usually a muscle that's been in spasm for some time, and due to the fact that the movement is limited, the patient will find that they've lost some of their range, and therefore the muscles get very tense. Their circulation is poor because they haven't got a good blood supply, the normal blood supply going through, and the movement is
Right, obviously.
So that muscle can get very painful because there's reduced oxygenation to that muscle. So here we are activating nerve supply and probably the vascular aspect, and you'll notice that there is a reddening around that.
Right, this is like a sympathetic reaction.
Yes, it's the triple response nerves which you get, which is really good for improving circulation underneath that region. So that is very important.
Excellent.
I thought what I might do is I might go to your T1.
Okay.
So just to show you your autonomic region. So 2, 3, 4, 5, 6, 7. Let's go to T1. T1 is at that particular level. We start there. You can go onto the spinous process, but it's better to actually go onto the lateral process. And I'm going to turn up the current now, and let's see if I can pick up. I might need a lot more because there's a lot more muscle underneath there. And I haven't picked it up yet. And I'm on 30. But even if you don't pick it up, that doesn't matter. You can see, can you see how the skin? I don't know if there's a skin reaction there on the your actual hair follicles. So that is a reaction. And also, in a patient that's got very severe problem, you won't pick up the stimulation as you did with this. You have to take a lot more higher intensity of current to pick up the circulation.
Right.
And in this instance, there may, for some reason, have been some form of injury that I didn't know about, and this may be the reason why. But very often with fibromyalgia, what we do is we work along with spine to get a stimulation there. There you are. Can you see that? That muscle? But it's not very strong. It could be much stronger. So I don't know if you've ever injured the side of your body before or had a neck problem on that side. I'm not sure. But that just shows you. So with fibromyalgia patients, you'll also pick up a spot that is going to be active. And the next time you treat this patient, you'll probably find that you won't have to use as high intensity. Also, you will find that other points will pick up the next time you go over that area. Excellent. So now I'd like to go to the auricular temporal nerve, or the auricular nerve for dizziness. I just want to see this is that.
Yeah, that's very interesting to me.
Yeah. There's such a wide variety of treatments that you can actually do with this, and many conditions that you can help. So we would use the occipital nerve for somebody who was dizzy. I would use it in that region, C2, and then I would also go to the inferior aspect of the ear, and even I would even go to the edge of the lateral aspect of C1, right into this point, and I'll do that for you now as well.
Okay.
I hope our time is okay.
Yeah, we have another 5 minutes or so.
Okay.
Yeah.
So sorry, I've introduced that one, sorry, make it harder. So let's say we go onto the edge of C1. Where does this refer to for you? Besides it's going into the sternocleidomastoid muscle, you can see.
Yeah, I can feel around.
Oh, good.
Yeah.
Yes, so it's going right into the temporal region. Yes. Okay. So that's why if you get to the edge of the vertebra, even if it is the transverse, the edge of the transverse process, yeah, I'm going down all the facet. I don't want to go too high. And then again, we can go to this nerve here, which could affect pain in the ear.
It goes all the way to the front, to my lips.
The front.
Yeah.
To the lips. Okay. So you can see that the referral is very wide indeed. So, okay, now, let's have you lying on your side, and I'm going to bring up a pillow here. I just want to remove the
all right.
I'm going to use again a different area. Okay. And I'm now going to work on the trigeminal nerve area. So I'm going to ask my patient to open their mouth. And I can feel the TMJ, and close your mouth. Do it again. Okay. So there's the TMJ. And I'm going to go just above it. And then I want you to tell me what you feel when I stimulate this nerve here. Because this is the first area that it exits the brain, the exit the skull. I'm on 5 milliamps. Can you feel anything?
No sensation yet. There we go. I'm feeling it to the front here.
Okay, that's...
Okay, so that's our whole trigeminal.
Yes. So that's on 12 milliamps. That's quite strong. I could reduce it.
You can see the orbicularis oculi.
Yes, yes.
Yeah.
So you are going to get, you know, it will go in the same area as your facial nerve, but the facial nerve comes out in this region here and then is accessible here, whereas the trigeminal nerve you can see is much higher.
Superficial there.
Yes.
Okay.
And I thought what I would do is I would just travel. I'm on 3 milliamps. Travel towards the orbit. Just keep your eyes closed. I don't want to get the gel in your eye. Can you feel anything?
No, I can't feel anything.
So it's on 3 milliamps. I'm just going to go slowly.
There you go.
You got something. So I'm on 4. And I can feel it. And you might move all the way along here depending on the type of problem that you have. Can you still feel it on the 4?
No, it's only there when you go back.
Only, so that's where the branch comes out. Let's start this again. And then, if I'm looking for the nasal area where you might get the nose, do you feel it?
Yep.
Yeah.
Or go all the way down to my front tooth.
Yes, yes. So you can see that you can pick up the branches. And then also, if we, let's just go, it's on 4 milliamps, that's not high. And let's just go towards the upper teeth.
There's nothing yet.
Nothing yet. All right, I'm going to go a little bit more. That's 5 milliamps.
There we go.
You're getting something in your teeth?
That's on the skin.
On the skin.
This area.
Okay. But the hand is going towards the inside side.
There we go.
You're feeling it there?
Yeah, it's going into the teeth.
Okay. But that is not part of the facial nerve.
Right.
It is trigeminal nerve. And I just want to drop it. All right, thank you. And then let's have a look here, because also you can treat your trigeminal nerve as it comes from this area here. It will come out of the orbit and then come upwards. So
that also coincides with an acupuncture point, isn't
yes, it does.
Yeah.
Can you feel anything?
Not yet. There we go.
What do you feel?
It feels like it's running along my head,
Yes.
going
All the way
towards the
back.
back.
Right.
So you can see how this is going to affect headaches from many different causes. And also, can you see how red your neck, the neck is in this region here?
Right.
It's very red. So you're getting a very large effect. We're looking at brachial plexus now. Let's just clean up a little bit.
I think we should just, wrap it up, Phyllis. So let's do brachial plexus and then
wrap it.
we'll wrap it up.
Okay. Sorry. Well, thing is,
nice,
what have I done?
Nice facial.
Sorry. Okay. So brachial plexus. Let's go. This is the area I would look for the brachial. There is the clavicle. Right. You've got an area inferior and you've got an area superior. So let's look here and let's look there.
And we are looking now for a bicep contraction, am I correct?
You will get a contraction on the whole arm. You could get the whole arm. Now I'm already picking up something. You can feel that contraction.
Oh, that's pretty.
It goes all the way down to my thumb.
Yes, that's right. So that's C5. I'm picking up C5. And now I'm going to go down. And then I'm going to go down below the clavicle. And I'll probably have to move a little bit more lateral. And this may be for a patient who's got an arm injury or pain in the shoulder. And you're also activating the pectoralis muscle. Let me just clean it up.
Excellent.
So there's such a wide variety of conditions that you're actually able to treat and very successfully, very quickly, and without medication, which is very valuable.
Fantastic. So these instances where Laurie immediately told you that there's a referral, you know, it either goes over his head to the back or from the back to the front. Like we mentioned earlier, would it be the norm for the patient to immediately respond and say, "That's my pain, and now it's gone"? Will when that nerve is triggered and that nerve is a specific origin of the pain, and you start treating it, will it lessen the pain?
It will.
So it helps as a diagnostic tool in that sense.
Yes, it does.
And I mean, many of the nerves that you treated are obviously combined motory sensory nerves. Do you find that the motory components, that the conduction actually improves as you carry on as well, so you get fasciculations easier? Because you did mention that you think that Laurie had an injury in his back because we didn't get a good fasciculation. So would it be realistic to expect that after a couple of treatments that fasciculation will improve?
And you see that most obviously in the glutes.
Right.
You see that in the glute muscles because they're so weak when you try to stimulate the sciatic nerve to start with patients with severe pain. And as the pain gets better, you get more and more fasciculation, more activity in the
Fantastic. Phyllis, thank you so much. I really appreciate you sharing so generously with us. I think it's great help for everybody to draw from your experience. I really appreciate it. Laurie, thanks for coming to have your headache fixed. I hope you're feeling better.
Feeling much better.
And I want to thank everybody for joining this webinar. It's a great pleasure. We will definitely keep in touch with you and let you know when our next webinar will be. Thank you for attending. Thank you so much.